It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription, or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Have a lot of cool things coming up. The first is the PainExam app, the NRAP app. You could just type in NRAP or PainExam into the iTunes store, or the App Store, I should say, on Apple. That's ready. So if you're studying for the boards or doing any sort of online, on-demand, regional anesthesia or regenerative medicine course or virtual pain fellowship, please download the app. And there's even a function for a community, which I'm going to develop so you guys could talk to each other, trade notes on board prep, jobs, the latest and greatest in pain medicine, etc. Secondly, lots of cool conferences coming up. ASPN 2024 in Miami this July. Check it out. It's always fun. You have the Congreso Internacional del Dolor y Paliativos in Mexico City. I'm going to be teaching ultrasound and talking there. You also have Florida SIP/Florida PMNR, Florida FSPMR. It's a meeting that takes place annually. This year it's in Orlando on September 19th to 22nd. I'll teach ultrasound there. We have Pain Week in early September, which is always a great time, a very interesting conference. I hope to be there. And of course, NICIP is coming up in November, a little later on in the year. And I have my own personal courses, which is the monthly ultrasound course in New York City. Next one is this weekend, Saturday, June 29th. And then August 3rd, followed by a 2-day regenerative pain medicine and ultrasound course at the end of September 28th and 29th. In addition, the PainExam app will be available on the Android platform soon. And don't get confused. There is a podcast app I created years ago with just a podcast. So we're talking about the board prep, the on-demand training courses. So definitely check it out. And you can always use coupon code PAINEDU, PAINEDU, for a discount for my courses, and as a thank you for listening to the podcast. So as you guys know, or might not know, I'm really interested in regenerative medicine. So I just found another article because it seems like there's always something new to talk about. A few years ago, I was doing a course in Jerusalem, and a lot of people were talking about Intraosseous PRP or BMAC injections. And at the time, I was not doing the interosseous injection. So I was just doing a search. I found a treatment by a name that many of you may know, Chris Centeno, who is pretty well known in the field of regenerative medicine. And the title of this article from Pain Physician is The Treatment of Bone Marrow Lesions Associated with Advanced Knee Osteoarthritis, Comparing Interosseous and Intraarticular Injections with Bone Marrow Concentrate and Platelet Products. So I'm not going to read the whole thing. I'm going to just paraphrase the key points. They mentioned that bone marrow lesions are a radiographic indication of bony pathology with advanced osteoarthritis or other pathologies of the adjacent joint. Injection of autologous orthobiologic products, including bone marrow concentrate, PRP, have demonstrated safety and efficacy in treating advanced osteoarthritis via the intraarticular route and associated bone marrow lesions via the interosseous injection. The relative efficacy of intraarticular versus interosseous has not been evaluated over time. So they aimed to evaluate the differences between the two, and they did a prospective case-matched cohort design in a single outpatient interventional orthopedic pain clinic. They used data from prospective orthobiologic treatment registry of knee patients, a population of knee osteoarthritis with bone marrow lesion patients who undergone only intraarticular knee injections of bone marrow concentrate and platelets for symptomatic advanced osteoarthritis. And they took into account age, gender, disease severity, case matched to a series of advanced osteoarthritis and bone marrow lesion patients who underwent interosseous plus intraarticular injections. Self-reported patient outcomes for numeric pain scale, International Knee Documentation Committee, lower extremity functional scale, and a modified single assessment numeric evaluation were compared between the two groups. The results: 80 patients were included, 40 in each group. Although pain and functional outcome scores were significantly improved in both treatments, there was no statistically significant difference in patient-reported outcomes based on the type of treatment. The study was limited due to the size and included multiple providers performing the injections, varying onset of symptoms to treatment, and additional injections after their initial treatment were not controlled. In addition, the increasing sample size may be beneficial, particularly with the large bone marrow lesion group, which did suggest possible improvement with interosseous plus intraarticular over the intraarticular alone. Although this was not statistically significant in their sample, limited data is available. So basically, I guess I'm not bringing much new to the table by talking about this study, but at least somebody is doing something about trying to figure out if we should be going into the lesion itself, which intuitively I would consider. I'm not that I'm recommending it, because if you have a defect, well, you might want to fill that defect with all that good stuff, that goodness from the platelets or from the MSCs. So I give kudos to these doctors who actually are taking a step forward and looking into this, because not every physician has the ability to carry out research in their practice, because it does take time, and you do need a team. And I did try to find more studies of this nature talking about the interosseous injections of PRP, and guess what? I did not find anything. I'm sure there's something out there, but it wasn't on the first few pages of my search, so I found something more interesting, and my ADHD carried me over to the topic of autologous ultrasound-guided PRP versus ultrasound-guided focal extracorporeal shockwave therapy for chronic lateral epicondylitis, a minimum of 2-year follow-up retrospective comparative study. And the reason why I care about this is because, well, most of you probably heard about the ultrasound focal extracorporeal shockwave therapy at this point in time. If not, it's something that is another cash-based procedure that people are marketing their $20,000 to $60,000 machine. In fact, I saw a nice ad on Instagram. I clicked on it, and as soon as they asked me for $60,000, and I expressed that wasn't going to happen, they basically hung up on me. So be wary of these companies. I'm sure it's a safe and effective therapy from what I've heard, and I can go into a podcast about that. But in this particular episode, I'm just going to talk about a study from 2018 where they compared the PRP and the ESW, and they did this for patients with the chronic lateral epicondylitis, retrospectively evaluating 63 patients, 31 with the autologous ultrasound-guided PRP injection, 32 with the ultrasound-guided focal electroshockwave therapy, and they used the Rolls-Maudsley score and the disabilities of arm, shoulder, hand, or the quick dash score and the VAS, as well as the patient-rated tennis elbow evaluation to assess these patients. And the results, well, both groups had effective chronic lateral epicondylitis improvement with the quick dash VAS RM and the PRTT scores with a p-value of less than 0.0001. No adverse effects, no differences found in recurrence and final results of quick dash VAS, the RM PRTEE scores, and if you don't know what that means, just rewind the podcast, between the groups with a p-value of over 0.05. The mean treatment time between treatment and symptom resolution was significantly shorter for PRP. Furthermore, the mean time to return to normal activities was quicker for PRP. So, lo and behold, by the way, if you if we always tell people, oh, steroid versus PRP, the PRP takes longer to work. Well, when it comes to the electroshock therapy, it looks like PRP is a quicker thing. So their conclusion, both PRP and the extracorporeal shockwave therapy are feasible, safe options for treatment of chronic lateral epicondylitis with low risk of complications and good long-term follow-up results. Ultrasound-guided PRP has quick efficacy when compared to ultrasound-guided focal electroshock therapy. That being said, I wanted just to, before I close out the podcast, make a note. So, I teach these courses, and I'm a real believer in PRP. I do my knee almost every hands-on PRP course I teach. I demonstrate while I inject my knee PRP because I'm trying to avoid knee replacement. And so far, so good. And the data to support that it will avoid knee replacement, well, I'm not aware of any particular one study. However, there's plenty of evidence that PRP keeps the joint in check, right? So, and I have a lot of those podcasts on the PainExam podcast, as well as the audio lectures on the PainExam board prep and online regenerative medicine course on my website. But I've been suffering from cervical radiculopathy for the last, on and off for the last 15 months, a year and a half. And I had one of the people at one of the doctors who appeared to know what he was doing, inject PRP into my neck. He did an ultrasound-guided periphyset. I have a C6-7 disc, and kind of extraforaminal injection of PRP near the medial branch nerve, the articular pillar, and I was sore for 2 or 3 weeks, kind of almost regretting doing this, and then all of a sudden the neck pain disappeared, and I've been suffering for well over a year. In addition, my arm symptoms, the radicular symptoms, are much better. They're not completely gone, but it was so bad, the arm symptoms, that I was getting chest pain as well, which you can get with a cervical radiculopathy. I had a cardiac workup and all just to make sure. But, it's really becoming clear that PRP is possibly, it should be a first choice therapy. Of course, the price is a little prohibitive for many people. And speaking of which, I'm about to consider the conspiracy theory behind why PRP is not covered. And I'm sure a lot of doctors don't mind that it's not covered, right? Because this is a cash procedure. Since we're underpaid for so many other procedures, it helps us meet our expenses. But Medicare has stopped paying for effective, proven procedures such as CPT code. I was informed, and if you know otherwise, please tell me. 64450, that's other peripheral nerve block code, for instance, cluneal nerve or like radial nerve, which in certain situations is, everybody's different, right? So some people do need a radial nerve block. Some people do need a cluneal nerve block. So the fact that Medicare will not pay for that code, and I even heard that they're not going to pay for genicular nerves, and I need to confirm that because maybe I don't want to give you the wrong information. But the fact that Medicare will cover their oxycodone and maybe other things that are not in the patient's best interest, but will not cover a lidocaine injection on a peripheral nerve when many times that does work, and there is evidence to support that. It makes me wonder, is there some sort of lobbying group from Big Pharma or somewhere else that is convincing them to deny interventional procedures and push people towards the medication route? I'm just wondering that, just a conspiracy theory type of thing. But having gone to Congress and and spoken to the representatives of the congressmen, they're just like, I don't know anything about highway construction. They don't know much about medicine and healthcare. Some of them do, of course, but some of them don't. And they need to be educated, and they can be swayed one way or the other quite easily. And even if there's no secondary game or like lobbying or bribes, I'm not talking about that. I'm just saying people don't know. So it's possible that someone's painting a picture that pain doctors are doing unnecessary interventions that are not helping patients and just draining the system of money. Whereas at the end of the day, it's all in the data. And then again, data can easily be manipulated. So I'm a little concerned for the welfare of our patients as well as healthcare in this country, because I just see that a lot of stuff is being denied. For instance, the 3 trigger point per year rule now Medicare does, it went from 6 to 3. And I know in other countries, people are getting trigger points whenever they need them, or at least way more often on their socialized health system or I guess private system. But anyway, there's a major problem with healthcare in this country. There has always been. Healthcare could probably never be completely fair because the people who need it the most can't afford it. And I think it just needs to be balanced, evidence-based, and the people making the decisions really need to know what they're talking about. And I would imagine it would probably be best if the pain doctors were making the decisions about pain management as opposed to politicians. Anyway, I'm about to get my day started, and I hope you guys have a great day. If you like the podcast, please review it, share it with your colleagues. If you don't have a moment, please sign up for the NRAP Academy. I'm going to create a community there so you guys could all talk to each other, trade secrets and insights, etc., about how to help our patients, as well as how to maintain and grow a profitable pain practice and pass your boards, importantly. Anyway, good luck, and thank you.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical.